The ABTA is pleased to welcome you back to our webinar series. Our webinar today will discuss Metastatic Brain Tumors 101. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker today. Dr. Minesh Mehta is a world-renowned expert in radiation oncology, proton therapy, and cancer research. He is the Deputy Director and Chief of Radiation Oncology of Miami Cancer Institute at Baptist Health South Florida and oversees South Florida's first and only proton therapy center. Dr. Mehta has designed and led several national and international clinical studies, receiving NIH and NCI grants. He has held national leadership positions in numerous organizations, including the American Board of Radiology, the FDA Radiological Devices Panel, the American Society for Radiation Oncology, and more. Dr. Mehta also serves on the ABTA's Brain Mets Advisory Committee. Thank you so much for joining us, Dr. Mehta. You may now begin your presentation.
Good afternoon, Umbreen. Thank you very much for that very generous introduction. And in this time of social distancing and isolation, I hope everybody is relaxed comfortably wherever they are, and we can enjoy the next 40-45 minutes of this presentation that hopefully will bring us up to speed on metastatic brain tumors. To begin with, let me just share with you my disclosures and support. They are listed on this slide and are available for further review if needed. The focus of my presentation today is going to be the following 4 key objectives. We will talk about the epidemiology. In other words, we'll overview secondary brain tumors or metastasis, and we'll also talk about what these mean for patients. How do patients present? What do they feel when they have metastasis to the brain? We'll talk about the types of different cancers that commonly spread to the brain and recognize that this is a very unique and substantial therapeutic challenge. And given the fact that this is a difficult clinical decision-making process, how do we discuss side effects, therapies, and management, and how do we include the patient in these discussions? And of course, we'll focus a lot of time and energy on understanding the standard treatment modalities, as well as new advances, which I'm really, really excited about, because for the longest time, we had very little that was a new advance, and now, all of a sudden, we are beginning to see a change in outcome based on some very novel things that are happening that we'll touch upon towards the end of the talk. So let me start first by talking about the incidence of brain metastasis. How common are these tumors? So we know that primary tumors, tumors that arise in the brain de novo, in other words, they haven't started somewhere else and gone to the brain, but have actually started in the brain itself, are actually quite uncommon. They represent less than 1% to 2% of all cancers that we see in the United States on an annual basis. However, cancers that spread to the brain, what we call metastasis, are far more common. And because they are a consequence of some other cancer, they may be a consequence of lung cancer, breast cancer, colorectal cancer, renal, melanoma, whatever, the actual incidence is not categorically known, because although we report cancer, we don't necessarily report every site to which the cancer metastasizes. And so our best estimates are that the annual incidence is anywhere between about 170 to 300,000 cases in the United States. This means that for every primary tumor in the brain, we probably have about 10 patients who develop metastatic disease to the brain, which makes this really the most common brain tumor. We know that somewhere between 1/6 to 1/3 of all cancer patients at some point in the natural history of their disease will develop brain metastasis. And the incidence of this is actually increasing as there are better therapies and longer survival of their primary cancers. We've all heard about the recent advances in the area of immune checkpoint inhibitors. And these have dramatically improved survival in many, many patients, including melanoma and lung cancer. And consequently, what we are beginning to see is improved survival in these patients, and therefore longer survivorship means a greater chance of developing brain metastasis. So it's sort of a good news, bad news kind of a situation. So let's take a look and see where these cancers come from. The most common source of metastasis, about half of all patients who develop metastasis do so from an underlying lung cancer. And then about a sixth have their metastasis attributable to breast cancer. And after that, once we take away about 65% or 2/3 of these patients from the mix, the rest 1/3 of the patients come from unknown primaries, other primaries, melanoma, colorectal, renal, etc. But as you can see, by the time we get to things like colorectal cancer, these are contributing to about 5% or less. But still, 5% of 300,000 is still 15,000. That's not an uncommon tumor. These are still substantial numbers, and they can't be ignored. But it's very clear that it's lung cancer that's dominating the picture. And if we took care of lung cancer, and if we modified the spread of metastasis from the lung to the brain, we would solve the problem in almost half the patients. So how do we know that a patient has brain metastasis? What do patients feel? How are they discovered? Well, when the lesions are large, they produce symptoms. Usually the symptoms are non-specific, like headache, nausea, vomiting, double vision, problems with balance and gait, sometimes visual disturbances, sometimes problems with coordination and speech, and occasionally seizures. But these symptoms are, of course, location specific, because if the brain metastasis occurs somewhere, say, for example, in the right motor cortex, which controls the left side of the body, then someone might have paresis or paralysis on the left side. And therefore, location is a critical aspect of the symptoms and the consequences of brain metastasis. We know that in today's day and age, a substantial majority of patients are actually asymptomatic. And they're asymptomatic because we use MR imaging at the time of staging. So more and more often, we're starting to use MR brain imaging when patients develop cancer, and we pick up small asymptomatic metastases on routine staging workup. And these patients really have no symptoms. This was really uncommon just 15 years ago. And now this is what dominates the picture: asymptomatic metastasis picked up on routine brain MRI. So now we have a patient with brain metastasis. And when this patient presents to a physician like me, what are the things we start thinking about? We start asking ourselves, what's the performance status of the patient? You know, how well or how sick is this patient in general? How many brain metastases are there? Are there just a small number, or are there a large number? Some patients, there's only one metastasis. In some patients, there can be 100 or more. It really varies by disease and patient. How small or large are these? Are they all tiny? Are some of them very large? Where are they located? Are they causing neurologic deficits? Are they causing brain swelling and potential problems in terms of a patient dying because of significant pressure or mass effect in the brain? What's the patient's age? The reason we ask this question is primarily because we use age sometimes as a surrogate and less often for overall general health. And it's simply not true that chronologic age has much to do with general health. It's really physiologic age. So although age is there, it's really the underlying physiology that we're looking at. Of course, we want to know about the primary tumor. What is it? What kind of a tumor? What is its stage? What is the disease status? Is it controlled? Is it progressing? Has it spread to 10 other locations, or has it not spread anywhere else? Does it have any molecular characteristics that allow us to intervene with targeted agents, which we know will give that patient a good chance of living for a long time? Is there extracranial disease? Has the disease spread not only to the brain, but to some other sites, to the bones, for example, or the liver? And is it progressing, or is it stable? And of course, the patient input is very crucial in all of this. What are the patient's desires in terms of being treated with this condition? Do they want us to be aggressive? Do they want us to be conservative? Do they want us to do everything possible? Do they want us to do only a handful of things? And if so, what are those things? So all of these considerations are crucial for someone like me as a treating physician. The reason for that is there are a number of different treatment strategies, and we would select the treatment strategies based on all of the variables we just talked about. It's not uncommon for symptomatic patients those who have brain edema and swelling causing symptoms, to be started on corticosteroids. Corticosteroids can have a dramatic, quick effect on the symptoms and are therefore very useful, but they are also associated with a whole host of side effects, especially if continued at high doses for a long period of time. And one of the most common problems I see in my practice is patients get started on a very large dose of corticosteroids, often 4 milligrams 4 times a day. There's really no good reason to give it 4 times a day, but that's a common schedule that's used. And then they're left on it, and people forget that these patients are on corticosteroids, and they come in with all kinds of problems. I just had a recent patient who called in on the phone saying they were feeling quite unwell, and they were about to go to the lab to have their blood counts checked because they were also getting chemotherapy. And we just asked them to have everything else checked, just routine laboratory testing, and it turned out that their blood sugar was over 500. And that's because the steroids had gone on unchecked for a long period of time, causing severe hyperglycemia and the symptoms associated with that. So we do see a lot of problems associated with steroids if they're not managed properly. The steroids are only symptomatic management. The actual treatment of the brain metastasis can range from the use of radiation, such as whole brain radiation, to surgery or resection of brain metastasis, after which one might or might not consider whole brain radiation or even stereotactic radiosurgery. Sometimes we use whole brain radiation with other drugs, such as radiation sensitizers or chemotherapy or targeted drugs, and sometimes we use it in combination with stereotactic radiosurgery. Increasingly, we are beginning to use stereotactic radiosurgery alone, sometimes with, but often without, whole brain radiotherapy. And a small proportion of patients can possibly be treated with effective systemic agents. We'll talk about who these patients are and what systemic therapies we're talking about, but this is a growing area of interest. So let's talk about whole brain radiotherapy, which has really been integral in the management of patients with brain metastasis for more than half a century. The main reason whole brain radiotherapy was used was because of its ability to produce symptomatic relief. It quickly relieves symptoms, but also because of the possibility that in well-selected patients, it might enhance survival. We know, for example, that in very, very old data, if we look at patients treated with corticosteroids alone, or those who received whole brain radiotherapy, those receiving whole brain radiotherapy lived for a longer period of time. And the reason for that primarily was stopping the growth of the tumors that we could see, but also decreasing the growth of new tumors in the brain by taking care of microscopic disease. However, a number of recent trials have raised very important questions that require a redefinition of the role of whole brain radiotherapy. And we'll look at some of these data in this talk. So let's talk about the two sides of whole brain radiotherapy. Why is it good and why might it not be good? It's good because it reduces relapse in the brain, both at the local site, that is the disease that can be seen on the MRI scan, and elsewhere in the brain, that is the disease that cannot be seen on the MRI scan because it's microscopic. The consequence of a reduction in intracranial failure are a limited or reduced need for MR surveillance, so we have to do fewer MRI scans. Otherwise, we're doing MRI scans every month or every couple of months just to make sure that new lesions have not popped up. And the reduction in the need for salvage treatments. If we did not take care of the microscopic disease, if we only took care of the 1, 2, or 3 lesions that we could see in the brain, we come back and do an MRI scan, there might be 2 new lesions. We take care of that, we come back with an MRI scan 2 months later, and there's 2 new lesions, and so on and so forth. So we're kind of chasing our tail when we do this, and whole brain radiotherapy can help reduce the need for salvage treatments. So then why don't we just use it for everybody if it's that good? What's the reason why we sometimes pause and ask ourselves, why could whole brain radiotherapy be bad in some patients? Well, firstly, it provides no overall survival benefit compared to stereotactic radiosurgery alone. This is a statement that's made all the time, but it is somewhat controversial because no trial has been done categorically to actually look just for overall survival benefit as the main or primary endpoint. And the reason for that is if there is a difference in survival, it's going to be small or modest, and it might only be in subsets of patients. So these are very complicated trials to do, but it's fair to say that the overall party line is that there's no overall survival benefit. So if there is no overall survival benefit compared to radiosurgery alone, why not just do radiosurgery alone? The other reason to pause when considering whole brain radiotherapy is the high rate of cognitive decline, at least as measured by sensitive neurocognitive testing. When we look for long-term memory, especially delayed recall, we often find that patients who receive whole brain radiotherapy do poorly on this. And so if there is no overall survival benefit, and if memory function, especially long-term recall, delayed recall, can be affected, then maybe it's worth just doing radiosurgery and delaying whole brain radiotherapy until we absolutely need to use it. So these are obviously some of the decision-making thought processes that go through the mind of a physician and the discussion that ensues with the patient and the family as to what the treatment goals are. Recently, and by that I mean about 3 years ago, 4 years ago now almost, an important trial was published in the Lancet known as the QUARTZ Trial. In this trial, almost 500 plus patients with non-small cell lung cancer with brain metastasis were enrolled, and they were randomized to either whole brain radiotherapy or best supportive care, meaning they did not get whole brain radiotherapy. Now, to get on the trial, patients had to be discussed in a tumor board, and the tumor board had to recommend against surgery or radiosurgery. In other words, the tumor board had to say, we don't think this patient can benefit from surgery or radiosurgery. In other words, things are really bad. And the physician says, I'm not so sure that whole brain radiotherapy is really going to help this patient. I'm uncertain. So you're already starting off with a group of patients where everybody says, I really don't think I can help this patient. I really can't operate on this patient. I really don't think I should do radiosurgery. And I'm uncertain whether whole brain radiotherapy will make a difference to these patients. Let's put them on this trial. And they did get on the trial, and lo and behold, we found there was no survival difference. Unfortunately, the survival was very poor on this trial, only about 8 to 9 weeks of median survival, which implies that this was an extremely unfavorable cohort of patients in terms of the fact that the patients were doing poorly and unfortunately did not have long life expectancy on their side. These are patients that in the practice in the United States, the trial, by the way, was from the UK. In the United States, when we see such patients, the discussion that we would often have with these patients is whether hospice care is appropriate for this patient or not. Because if they have only 8 or 9 weeks of survival, is it really worth making them come to the hospital or the radiotherapy clinic to get several days or weeks of care to not prolong their survival? It might be better that we manage their symptoms and have them be comfortable at home or at a hospice. And so the only conclusion we can draw from this trial is that if we take patients that are not doing well and are really better suited for a hospice type approach, then whole brain radiotherapy, and for that matter, any other therapy, will not prolong survival. So if patients are very sick, do not be heroic and overdo things because you will not benefit the patient. So that means there are different types of patients. Some do better and some do worse. And to try and tease this out, we use prognostic tools. And what you see on the slide in front of you is one of the earliest examples of the use of a prognostic tool. This is actually a simple prognostic tool. It was promulgated by Laurie Gasper and her colleagues back in 1997 using data from over 1,200 patients from clinical trials done by the cooperative group known as RTOG. These are brain metastasis trials that were done in the 1970s and 1980s. And what they were able to do was to develop what's called a recursive tool. You see that on the upper right-hand side of the slide. You don't need to read the details. I'll show those to you in the table below. Basically, if patients have a poor performance status of less than 70, in other words, they're doing poorly, they fall into what's called RPA class 3, and their median survival is very similar to what we saw in the QUARTZ trial, about 8 to 9 weeks, 2.3 months. If, on the other hand, they're doing well, they're functional, the primary tumor is controlled, they're younger than 65, these patients have median survival that's in the 7 to 8 month range. And everybody in between is considered class 2, and their median survival is about 4 months. So this gives us 3 different groupings of patients. The survival is still poor. The median survival is still measured in months, but clearly the class 3 patients do the worst out of this categorization of patients. And these are the patients that would probably best be referred to hospice. Now, in the modern era, we have revised these classification schema. We now do this by disease. So if we go back for a second and look at this recursive partitioning analysis prognostic tool from the 1990s, the primary tumor did not matter. We didn't really care about that because it didn't really have an impact. But today, we have what we call disease specific. That's what the DS in the title stands for. GPA description. The GPA here is not a grade point average, but it's a graded prognostic assessment. And as we can see by looking at these 6 examples of breast cancer, non-small cell lung cancer, small cell lung cancer, melanoma, renal cell cancer, and gastrointestinal tumors, the type of tumor does drive the outcome. So that's the first thing we've learned, that now, unlike in the old days, the primary tumor does matter. But beyond that, what we have learned, within each of these 6 disease categories, you will see that there are at least 4 separate survival curves. And they're all colored according to better prognosis versus worse prognosis. The curves in yellow represent the best prognosis. The curves in red represent the worst prognosis. So within each disease category, there are at least 4 subgroups in terms of prognosis, in terms of how well or poorly they do. And the patients that are in the yellow curves all generally do better than the patients in the red curves because they have a far more favorable prognosis. And if we now look at the scale on the x-axis, we're looking at scales of 24 to 36 months. Remember that in the past, we were talking about 7 or 8 months. So clearly, we're shifting the curves significantly in today's day and age. So how good is this disease-specific GPA description? Is it really relevant in today's day and age with all the new therapeutics that we have developed? To answer that question, a medical student of mine did a research project with me at the University of Maryland, and one of the questions we asked was whether patients are outliving their predicted survival. So this was a group of patients who were treated at the University of Maryland. We used the disease-specific GPA scoring index to predict how long they would have lived based just on the prediction model. And what we found was that the prediction model was not that great. 63% of patients outlived their predicted survival. That's great. So, we'd have told these patients based on the model, your survival is X, but 2/3 of the time, patients were outliving that survival. That's always a good thing. 1/3 of patients outlived their predicted survival by 100% or more. So they doubled it. And about 1/5 of the patients outlived their predicted survival by 200% or more. So clearly, as you can see from this red curve, significant proportion of patients are outliving their predicted survival, and some by 100 and 200%. And as you can see from the curve, about 10% of the patients outlive it by about 300%. So what gives here? Our models don't seem to be that good. What's the problem with the model? Well, what we're beginning to learn is that the models have to be constantly updated because the prognosis is constantly improving based on time. Here you see data that were presented at the ASTRO meeting in 2015, looking at the outcome of patients by this GPA scoring system and time. So patients in the blue curves were treated in the 1990s. The ones in the green curves were in the early 2000s. And clearly, the patients who are treated more currently have more favorable outcome. So prognosis is improving, and in part, this reflects the reason why the models are not exactly predictive all the time. So now that we have talked about more patients living longer, one of the questions we ask is, should we do more aggressive therapy, and who benefits from that? We wouldn't do that in patients that are unlikely to live long enough to benefit from it. So who are the patients that live longer who would benefit from more aggressive therapy like surgery or radiosurgery? If we go back to the surgical trials, here are 3 of them listed, and there were randomized trials. And in 2 of the trials, the numbers in green, which show the median survival in weeks, were significantly better than the numbers in red, which of course is also median survival in weeks. The patients with the green line numbers were treated with surgery followed by radiation. The ones with the red line numbers were treated with radiation therapy alone. The implication here is resecting the brain metastasis and then doing radiation results in better survival. But the key here is this only works for patients with a single metastasis. So if they have 2, 3, 5, 10 metastases, surgery may sometimes be necessary, but doesn't necessarily prolong survival. The third trial that you see at the bottom here showed no difference in favor of surgery. And that's because the performance status of these patients was not as good as in the other 2 trials. So not only is it necessary that a patient has a single metastasis, but that they have relatively good performance status in order for the benefit of surgery to be realized for these patients. The same thing applies to radiosurgery. This is an old trial that was published in the Lancet in 2004 by Dave Andrews. It's an RTOG trial. And in this particular trial, somebody's trying to access my computer. In this particular trial, stereotactic radiosurgery was added to radiotherapy alone. And as you can see from the blue curve, the patients with a single brain metastasis derived survival benefit from the addition of stereotactic radiosurgery, very similar to the surgery story. When we further parsed these data by looking at subsets of patients, we found that there were additional groups of patients, not just the single metastasis patients, but also those with up to 3 metastases and they were younger, that is less than 50, or if they had non-small cell lung cancer, or if they were in RPA class 1, which was the favorable class. These patients derived a survival benefit from the addition of radiosurgery to whole brain radiation. So these were the first data to show that aggressive escalation of radiation dose matters, and it matters in certain subsets of patients. We reanalyzed these data using the graded prognostic assessment index that I described to you, because that's a newer one. And now we see a much more dramatic impact. Look at the last line here. This is the group of patients that have the most favorable prognostic score. The score is between 3.5 and 4. And these patients have a median survival of about just under 2 years compared to 10 months with whole brain radiotherapy alone. So clearly, as you select more and more favorable patients, the magnitude of benefit goes up dramatically. The next slide here shows a summary of a number of radiosurgery trials published in the literature that either used whole brain radiation in addition or did not. And the key lesson here was that the brain failure rates went up if whole brain radiotherapy was avoided. And this is in fact better illustrated in the next slide that I'm going to bring up now. In this slide, we present the composite data from all of these trials. And what we see here is that if whole brain radiotherapy is withheld, which is the box in red, compared to not withholding whole brain radiotherapy, which is the box in green, and remember all of these patients got radiosurgery, the failure in the brain, anywhere in the brain, occurs about 50 to 78% of the time if whole brain radiotherapy is withheld, compared to about 15 to 47% of the time if whole brain radiotherapy is delivered. And the same applies to the local disease that was treated with radiosurgery and also elsewhere in the brain where there is microscopic disease. So clearly these randomized trials show that although whole brain radiotherapy does not improve overall survival, not utilizing it means that a very large proportion of patients, anywhere from half to 3/4 of the patients, will have subsequent failure in the brain. And again, that begs the question again, Why don't we just use whole brain radiotherapy in all of the patients? And the reason again for that is because of the fact that randomized trials have shown that memory neurocognitive function declines when we add whole brain radiotherapy. This is a trial published from the MD Anderson that shows that the mean probability of decline in memory is about 23% with radiosurgery, but goes up to about 49% when whole brain radiotherapy is added. So that's one of the reasons why we use whole brain radiotherapy judiciously. Now, we have talked about patients with a limited number of brain metastases. What about those with multiple brain metastases, such as more than 4 brain metastases? What do the data show? This is a Japanese trial in which over 1,000 patients were studied. And these patients had anywhere from 1 to 10 brain metastases. They were all relatively small, and all of these patients were treated with radiosurgery alone. What they found was that the median survival for patients with 1 brain metastasis was about 14 months. For those with 2 to 4 brain mets, it was just under 11 months. And for those with 5 to 10 brain mets, it was also about 11 months. And so the authors concluded that because the survival of patients with 5 to 10 brain metastases is similar to that of 2 to 4 brain metastases, that radiosurgery is appropriate for any category of patients up to 10 brain metastases. But we should pause here and make sure we don't neglect the data regarding the 14-month survival for patients with 1 brain metastasis. So effectively, what this trial is really showing us is that patients with 1 brain metastasis do much better. And as the number increases beyond 2, and it doesn't matter whether it's 2 or 8, the survival diminishes. So the other way of looking at this is that the glass is half empty as opposed to the glass is half full. And that means that the patients with more than 4 brain metastases need to be very cautiously followed because they do have a high risk of failure in the brain. We know from a recent trial of just under 800 patients from Wake Forest that the likelihood of dying from neurologic death is actually quite high as the number of brain metastases increases. And so I think the larger issue here is that as the number of metastases in the brain increases, there's greater burden of disease in the brain, and therefore there's greater likelihood of dying from progression of this disease. And maybe these are the patients we should be considering for whole brain radiotherapy. To do that, we have recently been studying a technique called hippocampal avoidance, which is a technique of avoiding a critical stem cell niche area in the brain that is responsible for producing new neurons that allow memory to be embedded in the brain. These neurons are quite sensitive. The stem cells that produce these neurons are quite sensitive to radiation. And in fact, it's possible that a significant component of the memory deficit following whole brain radiotherapy could be attributed to the radiation dose to the hippocampus. To determine if that is true or not, a recent trial, NRG-CC001, was conducted and completed. And this trial, the design of which is shown in the slide here, was very simple. Patients were stratified by their prognostic class and then randomized to standard whole brain radiotherapy with a neuroprotective agent called memantine, or this technique of avoiding the hippocampus and the drug memantine. Let's look at the kinds of patients that were enrolled. There were 518 patients that were enrolled on this trial. The median age was in the 60s. Most of the patients were RPA class 2, which is sort of that middle class in terms of prognosis. And the vast majority of patients had lung cancer. About 60% of the patients had lung cancer. In terms of the performance status, the vast majority of patients had a performance status of 70 or higher because that was actually an eligibility requirement in the trial. Both arms were balanced by these variables. The primary endpoint of this trial was the effect on memory or neurocognitive function. And the patients who received whole brain radiotherapy did significantly better than the patients who received memantine and whole brain radiotherapy alone without hippocampal avoidance. The dashed line represents the patients getting hippocampal avoidance. they have less memory loss, and the hazard ratio, the risk for this, is 0.756, which represents a significant protection of cognitive function for patients receiving hippocampal avoidance and the drug memantine. We also looked at patient-reported outcomes in this particular trial, and what we found was that the patients themselves reported by 6 months far fewer neurologic symptoms and far less intensity of their neurologic symptoms, implying that these neurologic symptoms were interfering less with the daily activities if they received hippocampal avoidant whole brain radiotherapy. So this appeared to be reflected in how the patients felt and functioned. As a consequence of that trial, a new trial has now just been launched, and this is a trial in patients with 5 to 15 brain metastases, and they are being randomized to radiosurgery alone or hippocampal avoidance whole brain radiotherapy plus memantine to try and determine if radiosurgery alone is as good as, or whether these patients continue to need whole brain radiotherapy. The trial is ongoing, and we don't have the results of this trial yet. So far, we've talked about radiation. Now let's talk about tumor biology, targeted agents, and novel drugs. We know that in the current era, especially in the arena of non-small cell lung cancer, there has been a substantial search for targeted agents that can target specific molecular alterations in different subsets of patients with non-small cell lung cancer. In this slide, we show the outcomes of 1,920 patients treated between 1987 and 2014 with a cumulative number of over 6,300 brain metastases. In this group of patients, we had the EGFR and the ALK status, which are molecular alterations, available in 306 patients. On the left, we see the outcome of these patients by their prognostic score. There are 4 different curves based on 4 prognostic classes. And on the right, the 306 patients whose EGFR and ALK status was available and their mutation status was positive. We see that within each class, if an EGFR mutation or an ALK mutation is present, the survival is better. So the mere presence of the mutation appears to improve survival. And it's not truly the mutation, it's really the therapy that's associated with the mutation. This is not just a one-time phenomenon. If we look at breast cancer by looking at HER2 amplification, patients with HER2 amplified tumors appear to have longer survival. If we look at BRAF status, if we look at ALK rearrangement, if we look at histology, all of these seem to impact what happens in terms of the biology of brain metastasis. So biology is becoming crucial in identifying which patients will live longer. Let me show you a very dramatic example. I'm going to start by showing you this particular case of a patient with numerous brain metastases. This is a patient with over 100 brain metastases, as you can see from all of the white spots on the 2 MRI images seen on this slide. And the patient is completely asymptomatic in spite of the fact that there are so many metastases, and that's primarily because of the fact that they're all tiny. The patient had an EGFR mutation, and because of the fact that the patient had an EGFR mutation, instead of treating the patient with radiation, the patient was treated with an EGFR inhibitor. And here is the dramatic result in terms of near complete resolution of most of the lesions and dramatic regression of the rest. There's still a couple of small lesions left behind. It's not a complete response of every lesion, but this is a very dramatic response to a single drug, a pill that inhibits the function of EGFR. So clearly, what we're beginning to learn now in the current era of targeted agents is that we have effective drugs and effective therapies that can produce dramatic responses. Is this a phenomenon or a story limited to lung cancer alone? And the answer is no. Let's look at data from melanoma. I'm going to show you a number of trials that have recently been published that have looked at patients with melanoma treated with immune checkpoint inhibitors. The first one was this trial by Marjolin in 2012, where patients with asymptomatic brain metastasis had a response rate of about 16%. And that doesn't sound like a heck of a lot, but in the pre-immune checkpoint inhibitor era, one would not even have seen a 5% response rate with systemic agents. So 16% is almost a tripling of what would have been expected. But since then, we've had a number of additional trials, and perhaps the most recent trials are the most illustrative. The trial by Long and one more trial published by Tobby show that in asymptomatic patients treated by dual immune checkpoint inhibitor, ipilimumab and nivolumab, the response rates approach 55%. So this obviously is significant. Now, this is obviously very, very good, but I think we still have to recognize that in the symptomatic patients, so even in the best of these trials, the one from 2019, the symptomatic patients have a response rate of only about 22%, which really should be labeled as modest. And we should not create unbridled enthusiasm that these modest response rates will dramatically change the outcome of patients with brain metastasis. Yes, it's good news that we're getting great responses, but I think it's important to recognize that they're limited to certain subsets. So if we look at, for example, the most favorable of the trials, the trial known as the Tobby trial, and if you look at patients that are on steroids to begin with, only 1 in 11 of the patients on steroids responded. So clearly the presence of steroids impedes the ability to respond to immune checkpoint inhibitors. So in patients who need steroids or have neurologic symptoms, we cannot rely only on immune checkpoint inhibition. It's a good therapy, but not good enough. So the logical and obvious question is, should we be combining radiation? So here are some early lessons that suggest that we should. This is a trial published in the Journal of Clinical Oncology in 2017 that looked at over 350 non-small cell lung cancer patients with EGFR mutation. And we see 3 different survival curves, the best one in blue, the worst one in yellow. The worst survival curve is patients treated with an EGFR inhibitor alone. The best one is combination of EGFR inhibitor and radiosurgery. So clearly survival improves as we add radiation. And we see the same theme in melanoma. This is a recent study from the French group that shows that when we add radiotherapy, the upper curve, the dark curve, is significantly better to immune checkpoint inhibitor therapy alone. So clearly the addition of radiotherapy to immune checkpoint inhibitors or targeted agents appears to be the phenomenon that moves the needle. We also know that upfront radiosurgery reduces local failure and reduces brain failure. There are 2 trials that demonstrate this phenomenon, that the use of radiosurgery and concurrent immunotherapy shrinks the disease faster, so you get a greater response, and there is a reduction in subsequent failure in the brain. So treating just with radiosurgery alone appears to decrease the subsequent development of brain metastasis when combined with immune checkpoint inhibitors. This is something we sometimes refer to as the abscopal effect, or an effect that occurs in an area that hasn't been treated. To test this abscopal effect, there is an Australian trial that has now been launched. And in this particular trial, patients will be randomized to a combination of dual immune checkpoint inhibition with ipilimumab and nivolumab, or the same systemic therapy with radiosurgery. So to try and determine whether the use of radiosurgery will not only decrease the failure of that treated lesion, but also failure elsewhere in the rest of the brain. So these are some of the new frontiers that we're beginning to explore in terms of combining various strategies, immune checkpoint inhibitors, targeted agents, radiosurgery, and the like. So let me conclude here. I think I have exactly a minute left. Brain metastases are a very common problem. More than half of all patients are asymptomatic at diagnosis. I would say that the overall survival still remains poor for the population of patients with brain metastases at large, but is improving significantly. And for certain subsets, the survival is dramatic. They do much, much, much better than historically. Resection improves survival in patients with single brain metastasis, and the judicious use of radiosurgery does the same. Whole brain radiotherapy, which was the long standby for almost all patients with brain metastasis, is now used selectively with the recognition that withholding whole brain radiotherapy increases brain failure rates, and this may be important in certain patients, and we would consider whole brain radiation in those patients. And if we are going to do that, we would consider using a technique known as hippocampal avoidance, which spares cognitive function. In the new era of targeted agents and immune checkpoint inhibitors which show activity, the combination with stereotactic radiosurgery might be the way to shift the needle, improve prognosis and survival. Thank you very much. I will stop here. And if there are any questions, I'll be happy to take questions.
Thank you, Dr. Mehta. We will now take questions. If you have a question you'd like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen, and we will answer questions as time allows. So, Dr. Mehta, one of the questions that we have here goes back to prognosis. So you had mentioned that prognosis has been improving over the years. Can you talk about some of the factors that have led to that improvement? And do you also see that there has been an improvement in early detection of brain metastases as well?
The answer to the second question is yes. And in fact, that partly answers the first question. There was a point in time when we would never do what's called a screening MRI scan on a patient with cancer to look for brain metastasis when we first diagnosed the cancer, because we considered it a low yield test. And therefore, we would never find these patients with small disease, small lesions who were asymptomatic. Only the patients that came in with symptoms would go for an MRI scan, and we would find somewhat larger lesions in these patients. Now that we frequently use MRI as a screening tool upfront when a patient is diagnosed with metastatic cancer, we are beginning to discover the disease earlier, smaller volume disease. Treatment of smaller volume disease obviously leads to better survival, and that's part of the reason why the prognosis is improving. But I think the other reasons that are responsible for improving prognosis include an improvement in therapy, the fact that we are using stereotactic radiosurgery in an increasing number of patients that improves local control of the lesions treated, the fact that we're using targeted agents and immune checkpoint inhibitors in subsets of patients where it works, that shifts the needle as well.
Thank you so much for sharing that. Do you know if there's a known time frame from the initial primary cancer diagnosis to when a brain metastasis might occur?
Great question. It's extremely variable. We clearly see patients that present with brain metastasis at the same time as their primary tumor. So the two seem to be occurring in tandem, which implies very, very early spread of the disease from the primary tumor. And we have also seen patients where that window is years and years long. So we call that time to brain metastasis, or TTBM. And in many studies, we have evaluated this TTBM. And in general, this is not an ironclad rule, but in general, the longer the TTBM, the longer the time to brain metastasis, the more favorable the outcome of that patient.
Thank you. And another question we have here from one of our attendees is asking, why do some cancers metastasize to the brain more often as opposed to others? Is it due to some sort of affinity to the type of cancer cell?
Obviously, the person asking this question must be a cancer researcher, because that's a brilliant question. That is such an important question, because the logical answer to that question is yes. There must be affinity. The truth is, we only have hints about this. We don't have good answers. We have hints that there are certain neurotropic factors in the brain that allow cancer cells to home to the brain, get attracted to these neurotropic factors, which allow the cancer cells to set up a home in the brain and grow. So there are things about the environment in the brain that stimulates cancer cells to go there. But we are now also beginning to learn that when we take patients who have a primary tumor and then they have a metastasis in the brain and they also have a metastasis somewhere else, not in the brain, if we take the tumor from the brain, the primary tumor, and the tumor from elsewhere, not in the brain, and we look at the genetic makeup of it, the genetic makeup of the tumor that goes to the brain is frequently different. In other words, it's not just the environment in the brain that attracted tumor cells, but there are certain tumor cells that evolve to have the ability to go to the brain. So they seem to preferentially evolve the genetic ability to spread to the brain. We're just beginning to understand that this phenomenon is truly going on. And if we could figure out the switches and the triggers that make this happen, we could potentially develop preventive therapies that prevent the development of brain metastasis, and that would be a fantastic day.
Thank you. And aside from the type of primary cancer a patient has, what are other risk factors that might lend a hand in the chances of that patient developing a brain metastasis?
So the question really is asking whether there are certain patients that have a higher risk of developing brain metastasis compared to other patients. And the answer is yes, indeed, that's true. Perhaps one of the first pieces of evidence supporting this came from the knowledge that there are certain histologic types where the likelihood of spreading to the brain is very high. So although lung cancer is the most common tumor we find in the brain, 40 to 50% of all patients with brain metastasis have lung cancer. If we look at the risk of developing brain metastasis based on the type of tumor one has, then melanoma very quickly takes the lead role. So clearly there are histologic types that are more likely to go to the brain, melanoma being at the top of the list. The second thing we discovered very quickly was it's not as simple as that. So if we look at breast cancer, for example, okay, in the remote past, breast cancer patients with brain metastasis usually were not patients that had HER2 mutations. And I'm talking about a point in time when anti-HER2 therapies did not exist. So we thought that HER2 positive patients did not develop brain metastasis. That's actually not true. The HER2 positive patients develop metastatic disease at a rapid rate, and in the absence of therapies, they progress and die before the disease develops in the brain. Once HER2 therapies became available, the picture changed radically, and HER2 positive patients whose disease was now being controlled with anti-HER2 therapies constituted a group that was more likely to develop brain metastasis. So in other words, if we change the biology that you live longer, then the likelihood of developing disease in the brain goes up. Diseases like small cell lung cancer, for example, have a very high propensity for spreading to the brain. So yes, there is unique biology based on the type of disease and the molecular makeup of the primary tumor.
Thank you. Another question we have here is from someone who has a primary brain tumor diagnosis, like glioblastoma. We've been talking about other cancers spreading to the brain. Is it possible for a brain tumor diagnosis to spread to another organ, like the lung?
Great question, and a bit unknown. The conventional wisdom is that the primary tumor spreads to different organs and locations. The question is really asking whether once a tumor has metastasized to a particular location, let's say the brain or bone or liver, can that seed off a clone that metastasizes somewhere else? Theoretically, that's possible. Not very easy, but possible. Because if you really think about it, once somebody has a metastatic lesion in the brain, if that metastasis is going to send out a clone of tumor cells, the only way those tumor cells get out of the brain is through the jugular vein, the venous drainage, which then drains into the capillary system of the heart and lungs, which means that it will get trapped there. And the implication there would be that once it gets trapped, it can't really go to another organ. Does that mean that brain metastasis would spread to the heart? Well, we hardly ever see tumors spreading to the heart. That's almost an unknown phenomenon. Well, does it mean that because the heart pumps blood out to the lungs, and that's where the capillaries are located, and small cells, including tumor clones, can get trapped, that metastasis should occur in the lung after they occur in the brain? Well, that's certainly possible. We don't see that commonly, and we don't see that often, so it remains a bit of an unknown.
Thank you, Dr. Mehta. Is there any difference between how brain metastases are treated in adults versus children who might have a brain mets?
Fortunately, the incidence of brain metastasis in children is rather low, so that's a good problem to have. That's not a common problem. And part of the reason for that is that the common cancers that drive metastasis in adults simply don't occur in children. Children don't generally get lung cancer. They don't generally get breast cancer. They don't generally get melanoma. But children do get sarcomas. And children do have hematologic malignancies like leukemias. So these tumors can, and they do have primitive tumors, primitive neuroectodermal tumors, for example, like neuroblastoma and others. These tumors can spread to the brain. And yes, in general, the treatment is similar to that in adults, except for the fact that when it's a hematologic malignancy, like a leukemia or something, then there is significant reliance on the use of dose-intense chemotherapy with or without radiation. Children also have a higher frequency of developing what are called germ cell tumors. And germ cell tumors, if they spread to the brain, are quite chemosensitive, and they can sometimes be managed with surgery and chemotherapy.
Thank you. And I think we have time for one more question. This question is asking about screenings for brain metastases. For cancers that have a high rate of brain metastases like lung cancer, breast cancer, some of those other cancers that you shared earlier, should these patients be getting screened for brain mets early on, or is there a screening process like that in place?
So yes and no. When we stage them initially, if they have metastatic disease, we certainly screen them at that point in time. At that point, if they turn out not to have brain metastasis, we don't have a routine for screening those patients every few months or so. And part of the reason for that is we don't have very good predictive tools to figure out who's going to develop brain metastasis. If we could fathom risk pyramids that would give us a risk score for certain patients having a higher risk of brain metastasis versus lower, then we could definitely do that and start screening those patients. We don't do that very well right now, but that is clearly a gap, an area of need that we need to develop.
Thank you so much, Dr. Mehta. That is all the time that we have for today. Thank you again, Dr. Mehta, for joining us and for your wonderful webinar presentation. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA's care line at 1-800-886-2282.